Dr. Jabir is senior consultant cardiologist at Lisi Hospital. He is well known to all of us, and he has organized many national conferences, and also he is the principal investigator for national registries, national team leader, and site P1 for international randomized controlled studies.
Thank you. Thank you, Sajesh. Thank you, Sajesh. Good evening, and it's a pleasure being here with you in this fine evening. And I thank Association of Physicians of India for this great opportunity. I'll be discussing about pregnancy and the structural heart disease, a heavy topic and a huge topic. So I'll be discussing some part of it which was specifically told to me, and rest we'll keep it for a discussion. I believe it's not the heart disease that complicates pregnancy. It's a patient with heart disease. The pregnancy complicates the heart disease because this pregnancy is one of the greatest workload for any heart. It's a workload for the normal heart. It's an extra workload for a diseased heart. So let's have a look at the hemodynamic changes in pregnancy. There's an increase in the cardiac output, plasma volume, heart rate, and a decrease in the peripheral vascular resistance, diastolic and systolic blood pressure. And everything goes back to normal by 6 weeks postpartum in a normal pregnancy. So what happens in the first week, the first trimester, the plasma volume, the cardiac output increases by 30 to 50%. It reaches the peak by second trimester. It reaches the peak by the second trimester, and then it plateaus. And after delivery, it immediately drops down and it reaches the normalcy or pre-pregnant values by 6 weeks postpartum. The plasma volume also, it increases and in parallel with the cardiac output. And there is a 10 to 20 beats per minute increase in the heart rate. That also peaks by towards the end of the second trimester and comes down immediately after the delivery. And a 20 to 50% reduction in the systemic vascular resistance, diastolic blood pressure, and systolic blood pressure. So it's a huge workload on the heart, any diseased heart. Increase in the heart rate, increase in the cardiac output, and it's almost like a volume overload. But at the same time, there are certain things that helps the heart disease also. That's a decrease in the peripheral vascular resistance. So there are certain diseases which is well tolerated during pregnancy, especially a volume overload of the heart, a regurgitant lesion of the heart, a severe aortic regurgitation, a mitral regurgitation. The pregnancy, these two diseases are usually tolerated well in pregnancy because of the decrease in the systemic vascular resistance. So what happens if you look at an echocardiogram? The aortic diameter may be normal, the LV ejection fraction remains normal, the RV ejection fraction remains normal, but there can be a small pericardial effusion, a small increase in the basal, right ventricular basal diameter, increase in the LA size, increase in the LA volume, increase in the LV size, LV mass. These are all normal during pregnancy, during the physiological changes of pregnancy. So if you see an echocardiogram which shows these or mentions these things, no need to worry about it, this is normal. This is the modified WHO risk score 2. The most important thing in pregnancy and cardiac disease is to risk stratify the disease. What is the problem we are going to expect? What will be the outcome, the maternal and the fetal outcome? We are more interested in the maternal outcome because the mother is more important than the fetus. Both are very important, but the mother is more important than the fetus. That is a basic principle of management of pregnancy-related disorders. So the highest risk is the WHO, the modified WHO class 4. It's an extremely high risk of maternal mortality to the tune of 30 to 50% or severe morbidity. Nowadays, in the modern era, we cannot afford a mortality. In the maternal mortality, it's a highly sensitive thing. Pregnancy and pregnancy associated disorders are all highly sensitive things. It's not like a normal thing because people expect this as a physiological thing. So which are the highest risk problems where pregnancy carries a big problem? Because this pregnancy, when it adds on to this disease, it increases the problems. We expect heart failure, arrhythmias, and even a mortality. Severe mitral stenosis, symptomatic severe aortic stenosis. I must say, a severe aortic stenosis per se may go through the pregnancy without problem with a T management, but a symptomatic severe aortic stenosis is a problem. And a severe regurgitant lesions are usually tolerated, but a severe regurgitant lesion with a left ventricular dysfunction, a symptomatic hypertrophic obstructive cardiomyopathy with a severe LVOT obstruction of more than a left ventricular outflow tract gradient of 50 millimeters of mercury. Eisenmenger syndrome is one situation where pregnancy is proscribed. If you know that this patient has Eisenmenger syndrome, and if they expresses the desire to become pregnant, it's better to discourage, because the outcome is extremely poor. Fetal outcome, very poor. Maternal outcome, maternal mortality remains high. A dilated cardiomyopathy with a severe LV systolic dysfunction. So cardiomyopathies, if it is a dilated cardiomyopathy, the outcome depends upon the LV systolic dysfunction. An ejection fraction of less than 30%, a NYH, a functional class of 3 or 4, they carries a high risk. And Fontan is nowadays common. Fontan is a single ventricle repair of a complex cyanotic congenital heart disease. So this a single ventricle, the functional ventricle will be a single, the RV may be non-functional. As a Fontan, now we call it as a Fontan circulation or a Fontan circuit, which with the complication is an extremely high risk situation. So if you look at the low risk, you can see a large number of common diseases are low risk. Any mild stenotic lesion, even a moderate stenotic lesion, mild, moderate, or even a severe regurgitant lesion without LV systolic dysfunction and normal pulmonary artery pressure, they are well tolerated during pregnancy. Left to right shunts without pulmonary hypertension, a small PDA, a small or even a moderate size or even a large atrial septal defect, ventricular septal defect, they all tolerate pregnancy very well. And a successfully repaired simple lesions like ASD, VSD, PDA, or an anomalous pulmonary venous drainage, no issue. And the moderate risk, unoperated large VSD or ASD, a repaired tetralogy of Fallot, most of the arrhythmias, mild LV systolic dysfunction, hypertrophic cardiomyopathy without much significant gradient, and a native or even a tissue valve disease where the functional class is better. The importance is for the functional class. He may be having a significant disease, but functionally normal, functional class 1, no symptoms. They'll tolerate the pregnancy well. And a Marfan syndrome without aortic dilatation, and aorta less than 45 millimeter in aortic disease, and a repaired coarctation. So these are diseases which can tolerate the pregnancy well. But the other one, the last group which I have already mentioned, apart from what all things I have mentioned, the addition is a mechanical cardiac valve, increased thrombogenicity, valve-related problems high, valve thrombosis high, a systemic right ventricle, complex cyanotic congenital heart disease, aorta more than 40 millimeters in Marfan, more than 45 millimeters in non-Marfan aortopathy, pulmonary hypertension. Pulmonary hypertension is a major determinant of cardiac mortality, maternal as well as the fetal. Any pulmonary hypertension is a problem in pregnancy. And LV systolic dysfunction I have already mentioned. And a previous peripartum cardiomyopathy with any residual impairment of left ventricular function, any residual impairment of ventricular function, usually pregnancy is proscribed. Severe stenotic lesion, severe mitral stenosis, severe aortic stenosis, and a severe coarctation. These are diseases where pregnancy is not well tolerated. So a valvular heart disease in pregnancy, the cardiac risk depends upon not the presence of valvular heart disease or not. It is the presence of certain problems of the valvular heart disease. How severe is the valvular heart disease? A severe stenotic lesion is always a problem, more problematic rather than a severe regurgitant lesion. Symptom status is important. Is severe mitral regurgitation, good LV systolic function, no pulmonary hypertension, and a functional class 1. They tolerate pregnancy well. If the symptom status is poor, like a symptom status of more than class 3 or class 4 New York Heart Association, they are likely to develop problem. And when we compare the stenotic lesions versus regurgitant lesions are usually well tolerated. Stenotic lesions are not well tolerated, of which mitral stenosis is the most problematic one. Aortic stenosis is the second one. Pulmonary hypertension, a real problem in pregnancy. Heart failure, significant heart failure is not well tolerated because it's an additional work overload on the heart, and pregnancy is one of the things that precipitate heart failure in a patient who is otherwise compensated. And of course, ventricular function. So mitral stenosis and the pregnancy, severe mitral stenosis, it's not usually tolerated during pregnancy, and they develop problems They develop heart failure. They develop usually heart failure towards the beginning of the second trimester, during labor, and immediate postpartum. So these are the three situations or three times, peak times of development of problem, and the problem is basically they will go into heart failure, pulmonary edema. A valve area of less than 1.5 square centimeter, usually not tolerated, and the most important predictors of mortality are the symptoms and pulmonary hypertension, and the mild mitral stenosis is usually well tolerated. Aortic valve disease. A symptomatic aortic valve disease, if the patient has a severe symptomatic aortic stenosis, that means a mean gradient of more than 40, and patient has class 3 or 4 symptoms. We have to discuss with the patient relatives. Of course, pregnancy, heart disease is a team. It's a pregnancy teamwork, or rather it should be discussed with the heart team in pregnancy. It's always better to correct the aortic stenosis before the surgery, before she becomes pregnant. Either surgical correction, the preferred valve is a bioprosthetic valve. The current day bioprosthetic valves are good, but once she completes her family and if it degenerates in 15 years, you remove the valve, and I am sure in next 15 years there is no need for a repeat surgery. We'll go for a TAVR. But we don't have a correct data on transcutaneous aortic valve implantation right now in pregnant patients. Asymptomatic severe aortic stenosis. If it is asymptomatic, aortic stenosis is severe. We look at two things. One, what is the symptom status? No symptom. Absolutely asymptomatic. LV function, no LV systolic dysfunction. If the LV function is good, then we can even subject the patient to an exercise test and look for any exercise related symptom development, fall in blood pressure, or electrocardiographic changes. If nothing is there, it's only a severe asymptomatic aortic stenosis with good LV systolic function. Exercise test, okay, normal. No ST changes, no arrhythmias, no blood pressure fall. Discuss with the patient's relatives, and if they are ready, then we can go ahead with the pregnancy and careful management and rest during the peak periods of the pregnancy. She may come out without much problem. Sometimes the patient can opt for a prior surgery or an intervention prior to it. And if the patient deteriorates during pregnancy, there is an option of a balloon aortic valvotomy. Mild or moderate aortic stenosis, they tolerate pregnancy well, and vaginal delivery is the preferred in most, and the cesarean session only for severe symptomatic aortic stenosis. Aortic regurgitation up to moderate aortic regurgitation is usually well tolerated. There is no need to worry about it at all. A severe aortic regurgitation can be problematic if they have LV systolic dysfunction. They can go in for a heart failure. So they may require a management of the valve disease prior to the pregnancy. And if you look at the guidelines, the 2025 guidelines, symptomatic severe aortic stenosis, class 1 indication means there is no confusion about that indication. Everybody agrees, and it's beneficial. Intervention is recommended before pregnancy in symptomatic patients with severe aortic stenosis, and also in pregnancy in women with mitral stenosis with a valve area of less than 1.5 centimeter square. And in pregnant women with a symptomatic mitral stenosis or pulmonary hypertension, restricted activities and beta blockers are recommended. So if the mitral stenosis patient is not going to undergo any intervention, she has decided to continue the pregnancy. There are two drugs which may be of benefit. One is beta blockers to keep the heart rate low, so it keeps the LA pressure low. It prevents a heart failure or a pulmonary edema to keep the heart rate somewhere around 55-60. And if the patient is still symptomatic, patient should be put on a diuretic. And in pregnant women with mitral stenosis, diuretics are recommended when there are congestive symptoms despite use of beta blockers. And full therapeutic dose anticoagulation is recommended in women with mitral stenosis complicated by the atrial fibrillation, left atrial thrombus, or a prior embolization. Surgical treatment is recommended before pregnancy in women with severe aortic stenosis or mitral regurgitation with symptoms, impaired ventricular function, or a marked ventricular dilatation. And diuretics are recommended for regurgitation lesions who have symptoms or heart failure. So in regurgitation lesions, we may manage it if symptomatic, severe LV dilatation, or LV systolic dysfunction. So class 1 means everybody agrees that the treatment is beneficial. Class 2A means majority of the people agrees that this should be treated and it helps. So intervention should be considered before pregnancy in those with asymptomatic severe aortic stenosis after counseling on the risk and benefits. The percutaneous mitral commissurotomy, if the valve is suitable for the balloon mitral valvotomy, in pregnant women, severe symptoms or the pulmonary artery pressure, systolic pulmonary artery pressure is more than 50 millimeters of mercury despite a medical therapy. And valve surgery, most of the times we would try to avoid a valve surgery during pregnancy because it carries a high mortality for the fetus. Valve surgery during pregnancy should only be considered when there is maternal mortality risk and other treatment options have failed. And class 2B in very selected symptomatic pregnant women with severe aortic stenosis not responding to medical therapy, we may go for a balloon valvuloplasty or transcutaneous aortic valve implantation. I have already mentioned the data regarding that is not great. So we can go for a balloon valvuloplasty. The problem with balloon valvuloplasty is the restenosis rate is high, so we may have to anticipate a definitive treatment in the near future. So it's a severe valvular heart disease, whether there are symptoms or not. If there are symptoms, intervene before the surgery. And if the prosthetic valve is required, preferably a bioprosthetic valve. It's a shared decision making. If there are no symptoms, exercise test. Are there provoked symptoms or not? If there are provoked symptoms, better to intervene before the pregnancy. If no symptoms, severe rheumatic mitral stenosis amenable to balloon commissurotomy. So even if there are no provoked symptoms and the mitral stenosis is severe, and if you can do a balloon mitral valvotomy, it's always do the balloon mitral valvotomy before pregnancy, because once the patient's pregnancy sets in, the volume overload comes, the heart rate increases, she can go in for a pulmonary edema. Severe aortic stenosis, valve intervention before the pregnancy is reasonable. Severe mitral regurgitation and the valve is suitable for a repair, not a replacement, a repair, mitral valve repair. If you can repair the valve well, if that is feasible, it's better to repair the valve before the pregnancy. And the infective endocarditis prophylaxis. Now the spectrum for infective endocarditis prophylaxis has come down significantly. It's usually recommended before dental procedures, gingival manipulation of gingival tissue or any manipulation of the periapical region of the teeth. Predominantly for patients with a prosthetic valve, mechanical prosthetic valve, or and biological prosthetic valve, and a transcatheter implanted prosthetic valve, or any prosthetic material used for a cardiac valve repair like annuloplasty, rings, cords, or clips. A patient who had a previous infective endocarditis, an unrepaired cyanotic congenital heart disease, or repaired congenital heart disease with a residual lesion, or any prosthetic material used for the repair, and post-cardiac transplant patient. For a vaginal delivery and a cesarean session, routine antibiotic prophylaxis for a vaginal delivery or cesarean session is not recommended. The prophylaxis for a rheumatic fever with carditis and residual heart disease or a persistent valvular heart disease up to 40 years or 10 years after the last rheumatic fever, or whichever is longer, who had carditis but no heart disease, 10 years or until the age of 21 years. Rheumatic fever without carditis, it is 5 years or up to the age of 21 years. The penicillins, the oral penicillins available is generally safe during pregnancy, and it should be continued. This is atrial septal defect. You can see it's a shunt, left to right shunt at the level of the atrium. The RA enlarges, the RV enlarges. In the long run, the pulmonary artery hypertension develops. Patient can go in for Eisenmenger syndrome. And nowadays, majority of the atrial septal defects we close with this device. It can be closed with a device, which is a percutaneous procedure, and it's a simple procedure. It gives a cure. Only very few cases, especially a large ASD where there are no adequate rims for the device to sit on, we may go for a surgical repair or sinus venosus ASD. Now we are doing intervention for sinus venosus VSD also. Maternal risk, low in unrepaired ASD if no PAH. Risk of arrhythmia is close to 5% and a 2 to 5% chance of paradoxical embolization. Small for growth, babies, it's close to 1/5. Perinatal mortality is somewhere around 2%, preeclampsia 7%, and what monitoring is required is we may have to do an echocardiogram at weeks 28. And large and hemodynamically significant ASD may close pre-pregnancy. And an aspirin or a prophylactic low molecular weight heparin for prevention of paroxysmal embolization. And device closure during pregnancy only if there is evidence of recurrent stroke. Same, the left to right shunt, a ventricular septal defect, a patent ductus arteriosus, a small VSD or a small PDA, nothing. Pregnancy is well to, even a moderate size VSD, moderate size PDA, no issue. Only thing is if there is significant pulmonary hypertension, Eisenmenger syndrome, arrhythmias, or a ventricular dysfunction. So it's size of the defect, the pulmonary hypertension, and the ventricular function. If these are all okay, patients will tolerate the pregnancy well. Small VSD, small PDA, repaired lesions without pH, normal LV, vaginal delivery is preferred. Usually they will be just like a normal one. Eisenmenger syndrome, anything, a VSD Eisenmenger, a PDA Eisenmenger, it's the highest risk for a maternal and a fetal loss, and I prefer pregnancy to be prescribed in this situation. I don't know whether we can consider about a surrogate pregnancy in that case. Another common cyanotic congenital heart disease is the tetralogy of Fallot, unrepaired congenital cyanotic heart disease. Heart failure, thrombosis, arrhythmia, endocarditis is close to 15%, not that low. And what is a maternal hypoxemia? That's the most important predictor of the fetal outcome. So there is a 10% fetal loss if the resting maternal SiO2 is more than 90%. And the chance of a live birth is 12% if the saturation is less than 85%. So in a cyanotic congenital heart disease per se, unrepaired thing, it's a problem during pregnancy. It's a great problem for the fetus. And if the saturation is too low, the fetal loss is extremely high. And pre-pregnancy counseling about very high risk if the maternal saturation is less than 85%, and we may have to use IV for IV tubes, the air filter. Repaired tetralogy of Fallot, low risk if there are no residual lesions. Risk of arrhythmia is close to 10% and heart failure is close to 10% if residual problems like a pulmonary regurgitation, an impaired right ventricular function, and severe RVOT obstruction. Fetal and obstetric complications close to 15%, preterm delivery, low birth weight. But repair tetralogy of Fallot, you can see that the fetal mortality is quite low, less than 1%. And we have to inform the relatives regarding the risk of recurrence, especially in the 22q11 deletion syndrome, 1 in half, 50%. What management they require if there is RV failure management, diuretics, bed rest, arrhythmia management, and if there is a severe outflow tract obstruction persistent or a regurgitation, she may end up in a problem. Vaginal delivery is preferred and cesarean section in severe RVOT obstruction or pulmonary valve stenosis. I have specifically asked to talk on the transposition of great arteries. Transposition of great arteries unrepaired, it is extremely unlikely that they'll reach to the level of adulthood to have a successful pregnancy. Extremely unlikely. So practically it's not required. So what we see is all repaired transposition of great vessels or some of the transposition of great vessels with severe pulmonary stenosis. So the saturated blood will be again routed back into the pulmonary artery. The right side connected to the aorta and the left side connected to the pulmonary artery. It's a circulation in parallel. Because of the connections in between, either a VSD or ASD or PDA, the patient survives. We have two types of repair. Either we switch the atria surgically or we switch the arteries directly, great arteries directly, and the best result is for an arterial switch that should be done within 4 weeks of the birth. So high risk pregnancy, major adverse cardiac events in 1/3. And atrial and ventricular arrhythmias in around 7%, heart failure in 10%. Arrhythmias, especially atrial arrhythmias, are very poorly tolerated, and this baffled, that is in the mustard or the Senning's repair, we change the atria, and there the leaks can lead to paradoxical embolization and desaturation. So symptoms of heart failure before pregnancy and RV ejection fraction less than 40%, that means it's a high risk patient. Fetal risk, 1 in 5 preterm birth, low birth weight, and neonatal death is extremely uncommon. And persistent pulmonary hypertension of the newborn in 7%. Every 1 to 3 months, we may go for echocardiogram and Holter monitoring if palpitations. Pre-pregnancy counseling, treatment of heart failure, treatment of arrhythmia, prolonged bed rest, and early postpartum follow-up with an increased risk of postpartum heart failure. Post-arterial switch, successful arterial switch, no risk, maybe 7% chance of ventricular arrhythmias and less than 5% chance of heart failure. Transthoracic echocardiography at 20 weeks, low rate of prematurity or fetal loss, and the vaginal delivery is preferred. Surgery before the pregnancy if the neo-aortic root is more than 50 millimeter or a severe aortic regurgitation. And the 2025 ESC guidelines for the management of cardiovascular disease and pregnancy, majority vaginal delivery is recommended, that is class 1. Antibiotic prophylaxis may be considered for delivery in women at high risk. And routine induction of labor prior to 39 weeks is not recommended in women with a stable cardiovascular disease. I may stop at this level and we'll take discussions regarding other things that I have left behind, like a mechanical prosthetic valve. So pregnancy complicates the heart disease rather than heart disease complicating the pregnancy. We have to risk stratify, plan. It's a teamwork. Cardiologist, the attending cardiologist, the obstetrician, anesthetist, physician, make out a definite plan. The team should discuss the problem with the patient and the bystanders in this area of high sensitivity pregnancies. And a team management is the key to the safe journey for the mother and the child. A planned definitive treatment of cardiac problem prior to pregnancy in high-risk cardiac disorders. High-risk cardiac disorders always treat it before becoming pregnant. The disease severity, functional class, ventricular function, pulmonary hypertension, and the complexity of the heart disease, that determines the outcome. And it's possible to have safe mother and child outcome in majority of the pregnant patients with common cardiac problems. Thank you so much for your patient listening.
So thank you, Dr. Abdullakutty. That is a vivid talk on pregnancy that is complicating your heart disease. Okay, so I wanted to ask one or two doubts. That is, after nowadays, this congenital heart disease is on the increase rather than rheumatic heart disease, because rheumatic disease is cured in the early period of the girl itself. So the rheumatic disease complicating pregnancies and the downfall, and the congenital heart disease which is complicating. Well, this pregnancy complicating the congenital heart disease. It is the adult, we call it as the adult congenital heart disease. Okay. Those people who survive with the congenital heart disease. So, after a correction of this AST or VST, after how long period that she can have a pregnancy? That is why one question. After correction of the ASD, if it is a surgical closure, we have to do a stenotomy. All the three situations except for the PDA closure, VSD closure, ASD closure, we have to do a stenotomy. So definitely after 3 months, I would prefer 6 months. And so after 6 months. 6 months. So then another thing is, one is infective endocarditis prophylaxis in high risk cases, and what is the drug that you prefer, and what is the dosage and how much it has to be? It's a big confusion because I've also referred to most of the guidelines. Yes. The guidelines just say in high risk pregnancy you may go for infective endocarditis prophylaxis. Neither they are telling about what is the drug, what's the dosage, because no consensus. The problem is in normal pregnancy, if it's a vaginal delivery or if it is a cesarean session, for a cesarean session, definitely there is no transient bacteremia. The principle of infective endocarditis is you have to cover up the transient bacteremia with a high bactericidal dose of an antibiotic. For cesarean session, of course, no. For a normal vaginal delivery also, I feel there is no much chance of a high bacteremia. Then, because in the new guidelines, they have removed the portion of genitourinary surgery, infective endocarditis prophylaxis is not recommended now. Because they feel that even if you give infective endocarditis prophylaxis, it's not going to change the outcome. But
in the Indian scenario, if the patient has a severe mitral stenosis, a prosthetic valve, a complex cyanotic congenital heart disease repaired, a heart disease, a cyanotic heart disease with a prosthetic material implanted, previous infective endocarditis, I would prefer an infective endocarditis for a vaginal delivery because there may be a bacteremia, the chance of a bacteremia because that area harbors bacteria. Ampicillin, 1 gram of the 2 gram of ampicillin plus or minus of gentamicin for the first dose, and we may repeat one more dose of ampicillin after 6 hours.
Yes.
2 doses. So the principle is, at the time of bacteremia, you are manipulating an area where there is bacteria and the bacteria enters the bloodstream. At the peak bacteremia, there should be a peak bacterial dose so that we should not allow the bacteria to come and sit on the prosthetic material or the valve.
So thing is that in an uncomplicated cesarean itself, we are taught us that we should give one prophylactic dose of cefalexin. That is first generation. That is what is taught.
Right.
So in a patient with a high risk case, with a cesarean section, should we give an antibiotic prophylaxis, and what is the dose?
For infective endocarditis, no.
It's a thing. That is our doubt. It's a thing. Thank you.
But now the preferred mode of delivery is mostly vaginal delivery in most of the situations. Very few situations where you promote a planned cesarean.
And cases where there is a cesarean section is required, it is obstetrically indicated. So in those cases with a heart disease, with a high risk heart disease.
Infective endocarditis per se, no, madam. But if there is an obstructive indication for antibiotic prophylaxis, general indication, yes.
Any questions from the floor? I think sir has covered the topic extensively and pretty well that we are not left with any questions.
Thank you.
Can I, Jabir, can I ask just a couple of, one is you mentioned diuretics in pregnant women. What diuretics can we give if there is, patient is having in heart failure or impending heart failure?
Loop diuretics, furosemide or torsemide.
What about management of AF in pregnancy?
The atrial fibrillation in pregnancy itself is a prothrombotic state. So if it is mitral valve disease, definitely we have to anticoagulate the patient. Rate control is the preferred modality of therapy because many of the antiarrhythmic agents are contraindicated in pregnancy. What we can safely give is a beta blocker, a calcium channel blocker, and digitalis. So these 3 drugs for control of the heart rate, and if indicated, anticoagulation. Mitral valve disease, definitely anticoagulation. Underlying LV systolic dysfunction, anticoagulation.
Thank you very much.
So one more question. That is an indication for an MTP in these cases.
MTP.
Termination of pregnancy.
Is it something that is going to involve a scraping or manipulation of the vagina or the urogenital tract? I would prefer to give a infective endocarditis prophylaxis if it's a diseases which I have mentioned before.
That's an indication for MTP in this heart disease, which are the cases which need to terminate
right, termination of pregnancy. Eisenmenger syndrome, severe pulmonary hypertension, severe LV systolic dysfunction, and a severe mitral stenosis. Severe mitral. And top list is pulmonary hypertension and heart failure. Intractable heart failure, severe pulmonary hypertension, Eisenmenger, complex cyanotic congenital heart disease. Complex cyanotic congenital heart disease, very rarely they come with pregnancy because most of the time they may not reach up to adulthood, but I have seen a few, maybe in the last 25 years, 3 or 4 patients who have come in the third trimester of pregnancy. I don't know whether they were concealing the fact or not, but they were absolutely clear that they didn't know that the person, the pregnant woman had any heart disease before. I've seen Eisenmenger also. And luckily all these patients came out of the pregnancy without issues, but it was a nightmare for the obstetrician as well as for the cardiologist.
So you are coming from an institution where there was a heart transplantation is being done. Have you seen any case after pregnancy after heart transplantation?
No, madam. We have done transplant, I think in my memory is right, only 2 people in the age group who can become pregnant. One has not tried so far. She had problems after transplant, then we managed it. She's currently doing very well. I think it's a 10th year of transplantation, but she didn't become pregnant.
Okay, thank you very much. Anyway, we can close this thing.
Thank you, Dr. Jabir, for that enlightening and clinically rich session.